Good morning,
Good
Doctor.
morning, we can hear you. Sorry.
I'm just killing the other computer so that we get that echo sound. So I hope everybody was able to recharge some brain cells after that amount of stuff we stuffed in here yesterday. First of all, I want to thank those people who have sent me their article that they've chosen. I sent you all an email, so you can just respond to that. I really would like to know what article you've chosen. I prefer if you actually read the article, or at least the abstract, but at least it helps give us an idea of the kinds of things that people have interest in. And it seems like right now the most popular article was about amphetamine, but beyond that, people have chosen pretty good mix of things. So please send that to me by the end of the weekend. I'm not able to follow what you're telling me if it's done on this chat, but thanks for about Gabbard. But yeah, be able to send it to me in email, and then I can keep track of it. But there are a number of, there's some sort of, a little bit of confusion with Dr. Papp and myself in terms of actually who are our students. Since a number of people were not on yesterday and have not responded to our various emails. And so if you are a student that was not here yesterday or did not respond to our requests about the two questions of what state you're licensed in and if you plan to pursue prescriptive authority and in what state, please do so. It would be very helpful for us. I know that there's one student, Mark, who I don't know if he's on today, but he was not on my email list, so it is on now. I guess you were recently added. So, are there any questions that people would like to start off for just a couple minutes as we kind of get our brains together of material that was presented yesterday, either Dr. Papp or myself? How should we study for the exam? So I talked about that a little bit at the beginning, is that it is a completely open book exam. Open book, you need to find a good source where you can look up medications quickly. I use Epocrates myself. It's free. I have it on my phone, and I can just look up mechanisms of actions, dosage, all that very quickly. But whatever you choose, it can be a book or something. So I think that's something, not a matter of studying, but what you're going to need for the exam to be more quick. Wait just a second. Since we have class again next week, and I'm hopeful the exam will be posted this week so it can be taken prior. Hopefully we'll have it in a day or two. How many questions in the exam and how long we will have to take it? It's whatever the standard is for Alliant. I'm not sure if it's 3 hours or 2 hours. Is there a standard for it?
Hi, Doctor. Yes, there is a standard for the exam. I can go through it after the class with you.
Okay. So, I mean, it's what we've done in the past. So probably, very similar, something like 25 questions in 90 minutes. I just don't remember. I mean, we teach once a year, so it's really hard to remember those sorts of details, but it'll be similar. But it's going to be a little different. You're not just drawing on any things that you've been memorized, but it's going to be how you're able to have a look through basically the slides are your textbook, and being able to access the information on them fairly quickly. That's going to be the most helpful thing for you. We're going to have we're going to post a study guide. That study guide will be posted. I've already sent it to your TA, and he will post it at the end of the lecture. So just go through, being able to understand the basics of those. When I've told you that you need to memorize something, I really suggest you memorize that, not just for the exam, but because it's something you need to know to understand the material in general and want to know it, if you're going to prescribe particularly. So if there are particular questions, while you're studying for this exam, please, feel free to email Dr. Papp or myself. We'll try to get back to you as soon as possible. And please, again, post the class in the subject line, so we'll know what it is rather than the volume of email I'm sure you get as well. So that'll help us identify. So any other questions? Okay, so let's start today. So this is going to be a fairly light lecture, this one. Thank goodness don't have to go through any studies, I don't believe. And then Dr. Papp is going to hit you hard with medication information. So let's go ahead and move along here. So, and I'm going to have the same problem I had last time negotiating this slide stuff. Okay, so we're going to hit 6 different categories of common prescribers' mistakes in terms of treating depression: getting it wrong, not picking up on cues, poor patient interactions, trying to do it all yourself, not adjusting to current factors, and then just medication mistakes. So those are going to be the categories that we move through here. And so let's start out with the case. So we're going to need the poll up to see it. So it's a pre-test, and then we'll find out how you did at the end. A case of Lei. So Lei is a 34-year-old female with a long history of depression. No visible poll for me. I don't think it's up yet, so it's going to take Aiden a little, maybe a minute or two to get it up. Oh, there it goes. She tells you she has been on many medications, but none of them really worked. One of them even gave her a rash. She states that sometimes she is anxious, but when that happens, she isn't depressed. Her mother took something starting with a Z, which seemed to help her. Which below are not important, or would you not do? A, find out the dose and name of each drug. B, prescribe Zoloft low dose and titrate upwards. C, investigate what she means by anxiety. D, order genetic testing. Or E, find out what drug gave her a rash before prescribing anything. So what would you not do, or what is not important? Okay, I would really love to see if we can get up to 100% on this poll. So let's give it another 30 seconds or so. Okay, so for those of you who have not voted, I sure hope you look at the answer, considering some of the wrong answers that I see in this poll. So the largest, I lost the poll. Okay, so the largest share was what you would not do. You would not order genetic testing. The next choice was that you would not prescribe Zoloft. And then the last poll, was find out what drug gave her a rash. So these are things you would not do. Okay. So getting it wrong, really wrong. So we talked about it a bit in the last time, is that one of the things that you're really going to get wrong is if you miss a bipolar disorder, and that's just not asking questions, the important questions. Does your depression ever go away completely and you feel really good? That's a red flag for bipolar disorder. So do you hear voices is going to be really a question of, is this a psychotic depression or something else? And then the sleep issue, do you have trouble with sleep? So 60% of people with insomnia don't have psychiatric disorders, but that means a good 40% of people do. So 80% of people with depression have some type of sleep-wake issue. So you need to really be questioning about the sleep issues when you're treating depression. insomnia usually occurs prior to the emergence of the major depressive disorder. So it could even, if somebody's not depressed, it would be something that, may end up with a depressive state, for example, in sleep apnea, as Dr. Papp talked last time. Insomnia is associated with a much higher lifetime recurrence of major depressive disorder, and it predicts recurrent episodes as well. So they're going to have a poorer response to therapy. So certainly in my practice, it is that if somebody has depression, it is the primary thing I talk about first. So I usually am going to talk about sleep, and I'm going to talk about some exercise if it needs some behavioral activation. So in terms of prescribing, the sleep issue is also going to be very important. It is also going to be very important in terms of which medication you use. And of course, the alcohol or other substances. Let me see the chat here. I don't have access to the poll, so I'm typing into chat, okay. I don't know why somebody doesn't have access to poll, but I don't know if Aiden can do anything about that anyways. So we're going to look at really the big picture of things. You're going to take a good history, especially the medical history. And this is where, if you're going to get prescriptive authority in particular, you're going to be trained on how to really get this good medical history in one of your internships. But even now, if you're not prescribing, think about asking important medical questions. So some of the things that I look at, ask pretty quickly are about, any medical conditions that they have, when is their last medical checkup, those sorts of things. So you can do that at this point. So, and if they give you some ideas of the symptoms, follow up on the cues they may give you. And Dr. Papp had mentioned some of this last time. So this picking up on cues, this obviously not exhaustive, but if they tell you things, you want to really think about how you're going to follow up. It may be subtle, it may be not. So some of the things that they're going to talk about may be non-subtle. So very often, patients will present a different range of physical sorts of symptoms as anxiety. So akathisia, and my guess is that you've seen this in one of your other classes, particularly if you've looked at antipsychotics, patients will call it anxiety, but it looks very different. And there's some great videos if you want to look at what akathisia really looks like. Hypomania can present as anxiety or ADD symptoms. So you want to investigate what they really mean by that anxiety. And something, as we're not really trained as psychologists in general, is to be looking at skin changes, but for psychiatric issues and medications, it is essential that you think about these sorts of things. So rashes are a big deal in psychiatric prescribing. And you want to be able to look and notice those sorts of things. And of course, bruises can be signs of abuse, but it can also be signs of SSRI side effects. So I think in general, as a psychologist, I used to tend away from ever saying anything about skin issues, that it was embarrassing for the patient, but it's something you want to talk explicitly about. And then again, there's sort of following up on the suspicious words. I feel wonderful, if it's very quickly and you're giving an SSRI, it could be bipolar. And then the obvious ones about addiction, that might be when they're not really telling you the truth. And then again, this sort of missing body language. I think, as a psychologist, at least I feel I was fairly well trained in this sort of thing in terms of really watching the body language. So I think it's going to be probably easier for you on that one. So I like to, there's an interesting little story that a psychiatrist told me about as he was supervising his residents, and the residents was going on. He was sitting there with the patient with him, and the resident was going on about all the psychological factors, and the psychiatrist said, well, do you notice anything about the patient other than that? And he didn't. And and the patient had a stroke, and half his face was down, and that was not even seen by the psychiatric resident. So it can be something we can overlook if we get too caught up in the psychological aspects of things. So poor patient interactions is another category of mistakes you can make. So this not educating the patient is really a lack of informed consent. So if you don't give them diagnosis, the diagnosis when you give a medication is part of the informed consent. So it's not just, so definitely, again, another major liability cause. It's not just about the diagnosis, of course. It's about talking about the risks, potential risks of the medication. And we'll talk about that later, about which sorts of information you give them on that. But if, for example, you don't tell a patient from 18 to 24 that they have a risk of suicidality from taking an antidepressant, you are not doing really your due diligence and not giving them enough information. I want to take a look now, see if I can switch easily on this thing. This not documenting is important. And we as psychologists document a little bit differently, but I want to share with you, and it's something that's posted as well. I want to show you an example. Now, can you see it? See if I can make it large. You have this, right? So I want you to show you a follow-up note. So this is a very complex patient. The initial note, I was trying to decide whether I was going to give you the initial progress note on this. It was pretty lengthy, but it becomes confusing. But I want you to look at sort of the extent of what has been documented. So it's giving a summary again. It's talking about the update of the patient, and really
sorry to interrupt, Doctor. Would it be possible to make it a little larger? I think it still is small to read.
So how do I do that? For some reason, it's coming up as a whole page, both pages.
Well, on the Mac, I'm not sure, but probably if you go to the layout up there, layout would let you to layout probably gonna let you to choose just one page show.
Just a second.
Yeah.
In that lower right-hand corner, you could probably just push plus where it says 125%.
Okay.
Okay.
Does that help? Is that big enough? Or not?
You can also choose that if you come a little lower with your pointer, it just show like just one page instead of two.
A little lower on my pointer.
No, up there under the design, there is, I believe that one, I cannot read it completely. It's about look like under the layout, but directly when you are in layout, directly under the design, what or the right one. I don't know what does one say. Does it say like one page? No, it doesn't say.
No. Okay, I think this is as big as we're going to get it. I don't see.
I mean, it's pretty big on ours.
Yeah, I'm sorry, I can't. We can't quite figure it out. This is again this new system that is a little bit confusing to us. So let's see if I can.
But it's 200% now, so.
Okay, so this is as big as I'm going to get it. If you think of it, it's too small. Do people want me to go over this or not? I think it's important. Increase the percent. So, okay, how did I put? I'm using a different computer. It's not mine, so it's even more tricky for me. So just a second.
should be in the view, I believe.
Lower right corner. Oh, here, wait. I'll do down here. Okay. Does that do it?
Maybe one to the left, to the view. There is also one that show like one page at a time. Yeah. I think that. Yes, I think that one. Yeah, that one.
Okay, is this okay for everybody? Okay. So I'm not sure if I'm going to be able to get to the next page, but okay. So again, what you look at the extent of this progress note written for a follow-up for depression. So at the beginning, we're reviewing sort of what had happened prior to this. Then we have an update, and you can see there's both a description, but there's description in terms of dosages, what's happening with the medication, sort of reviewing everything. And this is something when I did my training, I wasn't shown this sort of note. So I think it's very, very valuable. And I've got to tell you, I don't think that this is very common for people to be writing to this extent. But if you want to be a really good prescriber and really and not make mistakes, this is the best thing you can do for yourself, is learn to write really good notes. You'll notice up here he's talking about the psychogenetic testing that was done. Then again, another mental status exam being the mental status exam being performed each time, not just at an initial visit. We have the diagnosis that has been restated, and then obviously updated if you need to do it. An assessment here, again, sort of what had happened, and then this treatment plan. And we have the treatment plan talking about, here's what you're going to do with the medication, and a new medication that is going to start. Here, ketamine is being discussed versus alternative treatments of TMS or ECT. So this is where, again, this treatment-resistant depression, this patient is treatment-resistant, is discussing a higher level of care and how you would refer out for that, really giving informed consent. And you notice with the patient and the father present, so you've got the collateral in with you in order to discuss this, a higher level of care. Because if you have a very depressed patient in there, it's hard for them to get all that sort of information. When you're talking about medications, you may need to have more collaterals or more written information for the patient to take with them. Here, that sort of what you're doing on with other sorts of treatments, and here are here's the recommendation for outside provider. Again, this is referral, headache specialist. Suggestion to stay off video games and marijuana, so you're making behavioral changes and positive activities, informing the father, other family members, if there's any suicidal ideation, and when they're going to return for information. This particular patient is no longer benefiting from psychotherapy, so he was in psychotherapy, but no longer because of his severity. He's not really getting anything out of it, and they don't think about it as a best use of time. So I want to ask, is there any sort of are people writing? My guess is they're not writing notes quite like this themselves, but is this helpful for people to see this kind of thing in their training? Okay. Like I said, I never saw this sort of note, or really what would be expected kind of note to write from a psychiatric perspective. So I think it was important. And it's posted so you can look at it. Okay, let's see if I can, there we go, back there. All right. So I put this under patient interactions. It's not quite patient interactions, but hey, you got to choose where to put it. So anyways, back to sort of the mistakes with patient interactions. Obviously you're going to do the cultural factors and attitudes, but tailoring the treatment to the patient's preferences. You don't want to push your own agenda on them. So I think I mentioned last time, if they really prefer something like escitalopram to Prozac, even if you think Prozac's the best, you're not going to take it. And then you've got the problem that they're not taking medications at all. and that's not going to help anybody. So you don't want to, within reason, you don't want to think about forcing your what you want over the patients. So just a second. Yes, it is on Moodle, that particular progress notes, and we, any identifying data I think has been taken out. If you think something is identifying data in there, please inform us. I'd appreciate it. So I wish psychiatry was held to the same standards of documentation. So this is a psychiatric note. So I'm not quite sure what you meant by that. So in any field, you're going to have bad documenters and you're going to have good documenters. You're going to have good psychiatrists and bad psychiatrists, just like in psychology. How much time are prescribers allowed as opposed to usually a psychology visit? Well, 15 minutes, it depends on what psychiatrist you are. So if you're in private practice, they do just like most psychologists, they're going to do 50-minute sessions. I know Dr. Papp has an initial visit that's usually about an hour and a half, and then another hour writing up his notes, and then 30-minute follow-up session. So it really depends on whether you're in private practice, what agency you work for, and basically the level of dedication for the psychiatrist as well. So I think, although that's one of the reasons psychologists want to be prescribing, is that we see, these lower, patient interaction times with psychiatrists. I'd be careful about saying that it's all psychiatrists, because clearly it's not. And if there's one group of people that are strongly opposed to a psychologist prescribing, it's psychiatrists. So trying not to make blanket statements, I think, is helpful. So for some reasons, my slides are a little bit different. Okay, so this is purple just in order to wake you up, try to figure out why it's purple. So nothing different about the slide. But one of the mistakes you're going to make is trying to do it all yourself. As you saw in that progress notes, you're going to be referring out. You're referring out for sorts of therapies that you can't do yourself. You're going to refer out for sleep testing, a sleep study, if you think there's sleep apnea. And remember, sleep apnea is not uncommon. It happens and associated with depression. You're going to think about genetic testing, and I don't know if psychologists can actually do this themselves, but you can even refer them to another provider. I actually refer people to, if they're willing to do it, to something like Ancestry.com, where if you know how to grab off the data yourself, it's often not obvious how to do it, and then it's submitted to another thing, and you can get some genetic testing done there. So I use that in order to find out if the patient has the MTHFR gene in particular, or if they're a poor metabolizer. So if I don't have a cooperative psychiatrist, that's what I do. So the doctors and psychiatrists I work with prefer ABS format. No one writes notes that extent if time will not allow. Again, It depends on what group you work for, whether they're going to do long notes or not. And Dr. Papp, for example, worked at UCSD, which had very strict time limits about how you could be writing notes, but he wrote those notes in his spare time. So it will depend upon the psychiatrist, depend upon the agency, whether the notes are extensive or not. So I don't want to belabor this anymore. So you're going to really think about not doing it all yourself, inpatient setting, collaborative care. Get the family involved. If you have a very depressed patient, being able to help the patient understand the medication regime is very, very important, and it may take another family member to do so. So when to consider the inpatient setting? So, clearly there's that, financial piece of it, that you you may not be able to get someone to do inpatient. They may not be willing to do it, but it has certain advantages. So if you have an actively suicidal patient, so I don't even need to, shouldn't even put severe melancholia there, because melancholia itself is severe, or if they're catatonic. And this is the time to think a safer place for the patient. And they usually can't care for themselves when they've reached that pace. So a catatonic patient isn't caring for themselves. And when you put them in the inpatient, you can usually push the medication regime faster titration up or down, whichever way you need to it. And sometimes when a patient is on so many medications all at one time, you can withdraw them from all their medications and then sort of reset. So that I've recommended a couple of times, and it's been successful because it just becomes too muddled outside of it. And clearly, if there's a medically vulnerable patient or they're withdrawing from alcohol or benzodiazepines. So another mistake that you're going to be making is not adjusting to new factors. So you get really sort of locked into what you think about this patient, you get locked into what your diagnosis on, and you stop watching new stuff coming in. So changes in health conditions, for example, fluids, diarrhea, I'm still looking at this dialogue between notes, and yes, there is a difference between actual practice, but this note that I gave you, just so you understand, comes from actual practice. So back to this, changes in health conditions, fluid, diarrhea, and weight gain. So weight gain, you really have to be watching that. It's a sensitive topic for us to ask as psychologists, but you're going to have your scale there as if you're prescribing, and you're going to weigh your patient occasionally, because if you're giving them a medication, for example, if they're on paroxetine, that's Paxil, if they're on Remeron, if they're on an antipsychotic, it is essential that they're not gaining so much weight that it is a risk to the patient. And particularly if it's an antipsychotic, the weight gain can be associated with metabolic syndrome. So you're going to be watching out for this weight gain in various ways. If the patient catches the flu, for example, it's going to exacerbate the depression. So there are pretty detailed studies about the flu and how it exacerbates depression, but also can create a state of they don't have enough fluids if they're vomiting or they have diarrhea, and that's going to affect particularly things like lithium. And you want to be checking pretty continually about their over-the-counter substances they're taking or new medications. So I've got some patients, they just can't seem to understand the necessity of informing their provider if they've added new things. There's one patient, for example, she started taking spirulina, and she ended up with a manic event because it is high in serotonin. So there was an interaction between medications. So they don't think of sometimes as these herbal supplements as something to talk to you about, but it's something I query often with people. And then, the clear other sorts of signs of changes in socioeconomic status or relationship. So maybe we can get off okay, so, all right, not adjusting to new factors is another sort of thing we're still looking at in many ways as psychologists. So another way that you're going to have medication mistakes is getting it really wrong. Wrong diagnosis equals wrong medication. So if the patient has grief, i.e. there's not a severe level of pathology along with it, it's a short amount of time, it's not only give me the wrong medication, but it's not a medication. So underdosing or overdosing, just because they tell you that they're they're taking their medications as prescribed, doesn't mean they're doing that. So you want to ask more specifically, how many pills are you taking? How are you remembering to take them? And they fiddle with their medications all the time. Well, you know, I decided not to take it today because I was feeling good today. So you want to watch out for things that they're not telling you. One of the bigger medication mistakes, and we've talked about it last time, is about rapid initiation, rapid discontinuation. Particularly rapid discontinuation is much more likely to lead to relapse. And so you want to think about how you're going to help the patient taper off slowly if they're not, and premature discontinuation so they don't relapse. So piling up. So when you keep adding new medications, so they're having a side effect, so you add a new medication, then they have another side effect, and you add another new medication. That's called piling up. You want to trying to think about what's one medication that can do the whole job if possible, and then the obvious of not considering psychiatric co-occurring disorders. So this idea about non-adherence. So it's out there, and it's not just people with schizophrenia, which I think is something that we think it's more about with schizophrenia, but with major depressive disorder, it's 28 to 52%. I like the anxiety disorder. What I see in general with anxiety disorders, not taking a medication, is they're anxious about taking their medication. So 1/3 of patients don't fill their prescription, 1/3 don't take their medications, and 2/3 don't take the medication as prescribed. So of that group. So the reasons of non-adherence, again, this sort of fear of adverse effects. I see this often. Patients have a anxiety presentation, attitudes about their medication. We've all heard it. I don't want to take medication because it's not my family won't like it. I don't. I don't want to be a different person. And then there are actually adverse effects they may not like. They can become very impatient and demoralized from past experience. Things like, nothing really worked. And I've never had a medication that's even helpful for me. They may not be able to know how to take their their medications properly, or how you prescribe them. And I see this actually a lot, where I follow up on how they're taking the medications, and sometimes they're taking at night instead of during the day. If they are hard of seeing, they can't see how you've told them to take the medications. So let's look at kind of what to do about it. So adherence issues with attitudes. So really, what are you going to do? You're going to listen and help them with their issues. You're going to talk to them about it. Just informing them that it doesn't turn you into a different person can be really helpful for people, or this idea that they're weak. There are actually legitimate concerns about others finding out. So I've had a number of military people that come in that absolutely cannot be on medications. So I suggest things. So for example, the anxiety presentations, I'll suggest something like propranolol, a beta blocker, or something like that can help, but isn't going to be seen by the military as something that is they can't take. Okay, let me see. Yes, non-compliance with medication is really significant. And I think, Najib, are you a pharmacist? Anyways, so someone said, yes, it's really, really high. Yes, she's a pharmacist. So my guess is she knows that pretty well. Okay, will we be discussing taper medications? Absolutely. So yes, Dr. Papp is going to go into that in infinite detail. Yeah, that's a very important part. So he's going to go that in detail. So adherence is your fear of adverse effects. So depressed patients are very tolerant of any more averse stimuli. So if they become constipated, they don't like about it. And don't like it. They just don't want to take anything more that makes them feel crummy. So you're going to really help educate that patient. You're going to pick the medications with lower side effect problems, particularly for weight gain and sexual dysfunction. This is the primary thing I see over and over and over again, is the fear of weight gain and sexual dysfunction in patients, so particularly with males, for the sexual dysfunction, and weight for females, not to be stereotypical there, but that's what I hear. And then you're going to be judicious about how much you tell a very anxious patient about the medications, about what specific things you want to tell them about the side effects. I will discuss that later, and so will probably Dr. Papp. You're going to aim for that minimum effective dose, which decreases the amount of side effects, and the minimum number of meds, right? You don't want them having to look at, trying to monitor all those sorts of different medications for if there are real side effects. And if there are adverse side effects, you really want to monitor themselves. For example, like I mentioned, the weight gain, or things like skin rashes, picking up on those cues. So when changing medication in some cases may be better than just trying to add a medication for managing the side effects, but it really depends on the presentation. But add medications if change would be risky. So another cause for mistakes is this impatience. The patients need to be educated about how long the medication is going to take effect, that it can take quite a while to not both titrate up and to get the full effects of an antidepressant. And in some cases, you're going to add an initial adjunct medication. For example, highly anxious patient, you may add something like a benzodiazepine for a short period of time until the medication kicks in. Or for a very energic patient, you might add something like modafinil or a little stimulant of some kind. And then again, this idea of relapse, that belief that the medication is already done. So I feel better, so I'm going to stop taking my medication. I think is a pretty common thing we've all heard, even as psychologists. So you need to educate them about that. So I know you've covered this in other classes. I won't go into this much at all, but clearly some people just can't adhere to it if it's too costly or if they don't understand it. So you're going to use all those things. I know Randy Tackett is very good about having discussed this with you. So I like, so I just put in this slide. I don't recommend a particular app, but I'm becoming more and more aware in my practice that nobody fills out paper anything. It's rare to get them to do a mood chart on paper, or even do a CBT work with paper. So I'm moving more and more trying to give them apps to do this. There are a bunch of good apps out there. A bunch of good apps out there that can remind the patient. Some of the apps will actually tell the patient the level of adherence, and if you can get one of those, that would be even better. So you can't always take the patient's word for it. So let's go to, and I think is this my last slide? Just a second. Yeah, this is the last slide, and then we're going to turn it to Dr. Papp. So let's go ahead, and since we can't redo the pretest, I'd like you to answer what you think is the correct dose, the correct answer this time for this case. This is Lay, the 34-year-old female, long history of depression. What would you not do?
Good.
Okay. So it looks like most of you getting it right. The thing that you are not going to do is prescribe Zoloft, low dose, then titrate upwards. Can you tell me, even she said a Z, right? So can somebody tell me the most important thing that you see in this case that would say, do not just prescribe Zoloft? Yes. Thank you, Monica. First one, Daniel. Yes, rash. So this patient got a rash. You don't know what drug it's from. You don't know how severe the rash was. And so you're going to follow up absolutely on E, find out, and find out what drug gave her a rash before prescribing anything whatsoever. Rashes are not benign in psychiatry. So if she said that she'd prescribed Lamictal, well, it'd be more obvious, but any medication, you don't. So what's happening now? We've got people's visual on it that have popped up. Mark, got your visual, so can
that's my visual. Do I undo that?
Yeah, undo your visual and mute, please.
Okay, thank you.
Okay, so yes, you will not prescribe anything until you find out what that rash is. Clearly, she said order genetic. So we'd want to think about genetic testing. A number of you said that you wouldn't order genetic testing, but what is it in the case that says we probably should order genetic testing? So someone said D is an incorrect answer under most circumstances. So I don't understand what that means. Is D an incorrect answer? Yes, and so yes. So Joy, yes. And you said not immediately. Well, I would immediately. I mean, if I had the choice, and certainly if insurance was paid for it, I would do genetic testing because she says she's been on many medications, but none of them really worked. Well, I mean, there's a possibility that she's not taking her medications as prescribed, but why wouldn't you follow up on that? I mean, she may not be able to benefit from it. I don't know if you can do the testing or not. As yes, it's absolute. Someone said is absolutely indicated. I absolutely agree. I think if, like I told you, if I can't get a patient to get to a doctor to do genetic testing, or they don't have the money, yes, insurance will pay for genetic testing, but probably not in all cases, and depending on the insurance. I send them to one of these sites where they can do their own genetic testing with a spit test, and then you can actually download the raw data and you can find out your genetic testing. Is that the preferred way? No, but it can be the only way. Medicare won't. Is that true?
No, it doesn't.
No, according to Dr. Pat, Medicare will pay for genetic testing. Let me see, if she is referred out, will delay starting medicine, she may be frustrated and not come back. Well, no, you go ahead and you continue doing your thing. It doesn't mean you, so it doesn't mean you can't start a medication. So if you know what she's given as a rash, doesn't mean you can't start a medication, but you still want to send her for genetic testing if you can. May do it, it can be expensive. Well, that's what I'm saying. It depends on how much it's going to cost. It depends on the patient, but it's not something that you would not do, right? It's not saying that you have to do it or that the patient has to do it themselves, but it's not something that you choose not to do, only in a hospital setting. So I'm not sure what that means. It's hard for me to follow this conversation. But if you have the chance to do genetic testing, of course it's something that you would try to do. It's not that you would not do it, but what you would not do is prescribe Zoloft. I mean, there's certain, you got to think a little bit differently. There are things that are preferable, there are things that would be advised, but then there are things that you must not do in psychiatry. And so you must not prescribe a medication if you don't know what is causing the rash at that point, to the best you can, right? I mean, it could be that you'll never find out, and then you have to make the choice what to do, and you're going to choose one that is less likely to be something that's going to cause the rash. So in general, you want to find out what all the doses and names of the drugs are. And of course, you're going to investigate about the anxiety. But you want to think about what are things would be preferable, but then also things what you must not do in terms of psychiatry. So does that make sense? Okay, all right, so we're going to turn this over to Dr. Pat. So let me get up his, well, I'm going to let him do it because for some reason it's not coming up easily. Here. All right, turning it over to Dr. Pat.
Okay, this is Dr. Pep, and is the everything on? Okay. All right. Two things before I start the. Oh, thanks. One thing is, I just want to say about the genetic test. I have no idea whether it has to be a physician who orders a test. I think it can be a licensed provider. So if you're interested, I suggest that you get in touch with GeneSight. There's the GeneSight report that's uploaded on Moodle, and you can get the name of so you just go to genesight.com and ask them, can I, I'm a licensed psychologist, can I order a test? So you may be allowed to order a test. The Medicare is, at least in California, certainly covers GeneSight testing. So I have ordered Medicare GeneSight test to a number of Medicare providers. Medicare patients. The other thing I would like to reflect briefly is the note. This is the kind of notes that residents are required to write during their residency. The reason why they require to write notes like that, because notes like that organize the mind. When you write notes like that, then you really figuring out what you do and why, and making a plan for the future, and you do it in an organized way. So because I was expected to expect the residents write notes like that, I was writing notes like that to myself. So I have, I was able to criticize them from a morally defensible point of view. So I just simply continued writing these kind of notes because, again, I think that notes like that are organizing the mind as you are thinking about your patient. You don't necessarily have to write notes like that. And if you see patients for 15-minute med visits, which I don't, you certainly won't have time, and there's not even reason to write notes like that. But and I'm not suggesting that you write notes like that. The notes is there pretty much more just to see how you think about a particular case. And you don't have to write it that way, but you have to think that way. Okay?
I'll answer the question about the break.
I don't have the questions. We don't have a poll here.
She wants to know about the break, so I'll just say it'll be about an hour and a half.
Yeah, but why don't I have? Okay, so let's look at the medications. This is going to be a very, very dense presentation, and I'm going to just fly through some of the slides again, because this is more the textbook of the course than anything else. There's a lot of things that are crammed into it, but it's not that you have to memorize it, but you should be able to look at these slides when you are answering the questions to the exam. Okay, so that is just so annoying. That guy is not me, in case you're wondering. Probably gonna look like that in a few years, but not right now. So let's go through this very quickly. So these are the SSRIs and the SARIs. And as you see that some of them have other receptor effects. And besides the serotonin reuptake mechanism, they also affect other serotonin receptors. In general, these are the indications for these medications. The typical length of half-life is about a day, day and a half, with a few exceptions. They typically have these effects on sleep: decreased REM sleep, prolonged sleep onset latency, increased awakening, and also when you discontinue the medication, that you have a rebound on that. So sometimes people have increased dreaming, sometimes for months. This is not necessarily a bad thing. It usually goes away. These are the most common side effects of these medications, mostly nausea, headaches, and activation. The most activating is fluoxetine. The most sedating is paroxetine. The most cardiotoxic is citalopram, which I'm going to talk more about. And this is pretty much the best medication to use. Again, the green is the pharma evergreening green here. This medication, fluoxetine, everybody knows as Prozac, but they also approved it as Sarafam for PMS, PMDD. Is the exact same medication. There was never a reason to ever prescribe it as Sarafam. But if you see the name Sarafam is the same as Prozac. It has a very long half-life, so that's one of the exceptions. The drug itself is about 3 days. Metabolized by 2D6. The active metabolite, which is norfluoxetine, has up to 2 weeks of half-life. So it's a medication that gets out of the system very, very slowly. There are some other clinically significant side effects of 5-HT2C inhibition, which is probably responsible for the activating side effects. It also has an effect on allopregnanolone. Has some sedating effects as well, and depending which one is stronger in a particular person, you get an activated or a sedated person from fluoxetine. That's why when somebody says, well, you know, I don't want to take this medication because my friend took it and he couldn't sleep, doesn't necessarily mean that the other patient is not going to be able to sleep. Maybe he's going to be sleeping more, because people have different genetic makeups and they have either this or that kind of a side effect from the exact same medication. Okay, so that's an easy medication and very frequently used medication, but be mindful of the long half-life. Fluoxetine, very quickly, it has been approved for OCD, but it's a perfectly good antidepressant. It is very rarely used clinically, probably not a bad thing because it has a strong metabolic inhibitory effect. Sertraline, frequently used antidepressant, pretty average in everything, with the exception that it's a dopaminergic agent as well. Very easy to use. Paroxetine, Gampexiva is one of those formulations that are completely unnecessary, but it's available. Clinically significant side effect, it comes from the M3 and M1 and M3. There's muscarinic 1 and muscarinic 3 receptors. Causes sedation, weight gain. It is the medications with the highest risk of discontinuation symptoms. It is to be avoided in pregnancy, but interestingly, it's preferred in breastfeeding because they're the least likely to pass into milk. I recommend it not to use. Recommend not to use this medication. If somebody comes to see you and the patient is on a medication, then there's no problems, continue, but I would not recommend starting anybody on this medication at this time of practice. Citalopram is one of the early antidepressants. It was, as you remember from yesterday, it was the base medication in the STAR-D study. It's a racemic mixture of S and R, citalopram. It is recommended in this dose, but clinically sometimes, as you saw it on the slides, people use up to higher dose ranges. I put it in red because it is really to be avoided. You should never go over 40 milligrams, especially in women. Normal half-life. And I would like to talk about the R-citalopram. So R is one of the two. Citalopram is the mixture of S and R. The R enantiomer is not only not an SSRI, but actually it interferes with the effect of S-citalopram on the transporter because it's a negative allosteric modulator. So it makes it more difficult for the S-citalopram to inhibit it. And it can also cause QTc prolongation over 40 milligrams of dosages. This makes citalopram to be the most cardiotoxic of all SSRIs. It's almost like a TCA. Metabolically, it's benign. But because of this effect, because of the R version, it is, I would say that avoid this medication. Again, if somebody comes to see you and on citalopram, and no problem, continue, but don't start anybody on citalopram because of that. And if we didn't have escitalopram, say, okay, use citalopram, but since we do have escitalopram, that's the medication that I would recommend to be your medication of choice, the starting medication, anybody who has never been on antidepressant before. Okay.
Question.
Okay, I know. I thought I saw a question. There's no question. Again, remember, this would be the medication I recommend to be starting with. The next two are brand-only medications, vilazodone, Vibrate. You know, it's really no particular need to start anybody on Vibrate. It is nothing special about it. It's one of those Me Too drugs. Vortioxetine Trintellix is a little bit different. It is the last SSRI approved and probably the last ever. I don't think there's any more SSRIs ever going to be coming on the market. It's a little bit different because it does seem to have some cognitive enhancing effects in MDD and seem to have the lowest sexual side effects of all SSRIs. And reluctantly, I started using it. And in fact, I did see a particular patient who I started on vortioxetine that said, yeah, you know, he's a writer. And he said that he has been changed to his medication. He has been writing better. His writing abilities improved. And on many patients, I have seen some lessening of the sexual side effects or no sexual side effects. But again, I had patients taking it and they just had full sexual side effects. But again, it's a medication that you may want to consider. It's a medication with long half-life. Not as long as Prozac, but much longer than the usual. Okay. Also brand only, but it's not very difficult to get authorized. Trazodone. Now, you wonder why I spent so much time, so much information on trazodone, which is not really used as antidepressant, as a sleep medication now, even though it started out as antidepressant. It is actually the medication most frequently prescribed in the US for sleep. And there's nothing wrong with it. It's very easy to use medication, but it can be very tricky. It's very short half-life, which is useful for being a sleep medication. It has some anti-anxiety effect. It has some sedating effect. The alpha-1 antagonism is significant, mostly in elderly, because it can cause orthostatic hypotension, fall. There's a risk of falling. Priapism is an interesting side effect of this medication. If anybody doesn't know what it is, let me know. Every single man who is prescribed trazodone has to be warned about this potential side effect. I have met a few men in my practice. Actually, both of them were given trazodone in prison, and they got priapism, and nobody bothered to take care of them, and they lost their ability to ever having erection later. So it's important that people know about it. There's even a risk of clitoral priapism in women, much less frequent, but if you read about trazodone, it has been reported. Now, it is a metabolism that's interesting about it because it's metabolized by 3A4 to something called MCPP. It's a toxic metabolite because it's an agonist on all the serotonin receptors instead of being an antagonist. So basically, it wipes out the antagonist, which is the anti-anxiety, the antidepressant effects of trazodone. And it can cause headaches, agitation, dysphoria. So some people, you take them trazodone and they feel horrible. These people end up with a high level of MCPP in their system. How does it happen? These people are hypermetabolizer on 3A4, but poor metabolizer on 2D6. So all the trazodone they take immediately gets transformed into MCPP, but then it's stuck there because it's not metabolized by 2D6. That limits the effect, the usability of this medication in some people. Okay, so be aware of that. If you give a medication to this patient and says, "Oh, I took it and I had the worst night ever," then that's what happens. So don't use an antidepressant, but don't forget that it's an antidepressant. What do I mean by that? So don't use trazodone for sleep on a bipolar patient. And be aware of this particular nasty side effect. Nefazodone is a nice medication, a good medication. Has fallen out of favor because of fears of liver causing liver disease, which it can, but other medications can also cause liver disease, which somehow escaped this negative validation. It is very similar to trazodone in terms of neurochemistry and effect as well. It has an even shorter half-life. It is clinically very similar to trazodone, except that it does not have an antihistaminic effect. The nice difference, and that's one reason why it actually is good to use sometimes, that it increases REM sleep as opposed to all the other antidepressants. And if you discontinue it, there's no rebound. There's low sexual side effects. Hepatic injury is there, but it's not a huge risk. Duloxetine and SNRI is very comparable. There are deaths reported by both use of duloxetine and nefazodone. It is also metabolized to MCPP, and the exact same thing can happen with nefazodone. So sometimes people have just the opposite reaction than what you would expect. Okay, let's do a little quiz. Could it be put up, please? Which of the following is false? The half-life of norfluoxetine is about 14 days. Or citalopram is not an antidepressant. Vortioxetine may improve cognition in MDD. Sertraline is a dopamine reuptake inhibitor, and trazodone is the drug of choice for insomnia and bipolar disorder. Which of the following is false?
I apologize, doctor. I don't have this question as a poll. Maybe you can answer in the chat room.
All right, chat room.
They got it all.
I don't see it.
Yeah, they're.
Oh, okay.
Mostly.
Okay, that's pretty good. The half-life of norfluoxetine is 2 weeks, which means that if you discontinue Prozac, and you know that it takes 5 half-lives for the medication to clear out of your system, it is almost 2 months for the fluoxetine to be fully out of your system. It's usually by 5 weeks, it is down to very little. Yes, R-citalopram is not an antidepressant, and the rest is, yes, it's true. And trazodone is not the drug of choice. SNRIs, there was this like second generation is this, of the second generation of antidepressants. The first one was venlafaxine, and then this was these are the others. In general, they share all the side effects with the SSRI, with some additional one which has to do with the norepinephrinergic effect. These here are the norepinergic side effects: dilated pupils, dry mouth, excessive sweating, and constipation. Tachycardia, hypertension. This is probably the most clinically significant. Excessive sweating is probably the most subjectively annoying. If you get SNRI induced hypertension, then you can try dose reduction. You can try to switch to a different medication. If really it's the only medication that the patient has been helped by, then you need to get them on an antihypertensive agent. Discontinuation symptoms are the most likely to occur with venlafaxine. The most hepatotoxic of them is duloxetine, almost as hepatotoxic as nefazodone. So let's talk about the venlafaxine a little bit. It comes in two that's the first version, the Effexor, and the few years later, Effexor XR, which is an extended release version of it. It has a very short half-life. The extended release about 10 to 20 hours, so it's getting closer to almost like a usual SSRI half-life. The norepinephrine effect is dose-dependent. Under 150 milligrams, especially under 100 milligrams, it is pretty much an SSRI, and the SNRI effect begins to appear over 150 milligrams per day. And at around 300 milligrams, it is now full SNRI. Interesting thing to know, a good thing to know about the brand XR, it's in a capsule form, and it is eliminated undigested, and sometimes people may come to you and say, well, it looks like I pooped out the medication, and does it mean that I didn't get anything out of it? Yes. It got absorbed out of the capsule, and the blank capsule is voided out. But again, it's kind of questions that you can get from patients. Diarrhea can interfere with the absorption because it's such a short acting medication. No, diarrhea, I didn't see my own slides because of these windows here. So diarrhea can interfere with the absorption of the extended release medication. The extended release is extended because it stays in the gut system for a long time. If it gets expelled too quickly, then most of it is not going to be absorbed. So people who have taken extended release medication, actually it's true for many extended release medication, they develop diarrhea, they suddenly begin to lose the effect of the medication. So that's one of the times when, let's say, something happens, like as Dr. Myers mentioned, suddenly diarrhea appears, and all of a sudden there's a reduction in the effect of the medication. CYP effect is not very important. 2D6 converts into desvenlafaxine, which is an active metabolite, so active that actually was turned into its own medication called Pristiq. It is an these windows just keep popping up here. It's an SNRI in any dose. Because of that, it's perhaps a little bit more advantageous to use. I don't stop using venlafaxine just because desvenlafaxine is easier to use. It is the same medication in any dose. It is also not metabolized by anything. You don't have to worry about metabolic interactions. Maybe a little bit less side effects. So I think it has slight advantages over venlafaxine because of its simpler profile. So if you need an SNRI, I would say that should be your first choice. Duloxetine is in delayed release formulation only, at least the brand. I think there are some immediate release generics now. Interestingly, it morphed into a pain medication. I've almost never seen prescribed for depression, but it has been become a favorite of pain physicians for chronic pain. But it's an antidepressant and it's approved for that, and you can use it. It's pretty balanced. Again, think about liver toxicity. Can cause urinary retention. In fact, it is used to treat stress incontinence sometimes. Like I said, this is nowadays probably the most frequent use of duloxetine. And again, you're going to see, maybe you see patients and they're telling me that, I'm not taking any antidepressants, I'm just taking pain medications. And it turns out that, yes, they are taking antidepressants. So we have to be careful because you don't want to prescribe a second serotonergic medication to someone who's taking a quote unquote pain medication for fibromyalgia. Milnacipran is another SNRI, FDA approved for fibromyalgia only, but again, it's a perfect normal antidepressant and it's used in many, many countries as such. It is a little tricky medication. I think that this is the one that has the most higher risk of causing high blood pressure and tachycardia. I've tried it a few times, and every time I tried it, or most of the time I tried it, I had to stop it because patients complaining of the side effects. There's levomilnacipran, is Fatsima. It is the form that's approved for depression. It's the same idea as Celexa or Lexapro, but there's absolutely no clinical justification because they are there's no difference. The dextromilnacipran is not, it's just simply not active, so it doesn't do anything. If you need an SNRI, this is the one that's not metabolized by the liver, so it's another one that you might want to favor over the other SNRIs, but I would say that you can just safely avoid using it in your clinical practice ever. Atypicals, bupropion. You see this little, the sketch of bupropion. What is the red part of this up here? What is that? What is the structure of? Anybody knows? Okay, so anyway, so the red.
I think you have to look at the chat to see our responses.
Yeah, so I'm thinking of the answers. The answer is this is amphetamine. So the structure, the red part is amphetamine. So this is an amphetamine-based medication. And don't forget, amphetamine was the first antidepressant. So the thinking behind developing this medication is correct. It's a very short half-life. There is a slow release and extended release with lower half-lives. It has no serotonin effect. It's a norepinephrine dopaminergic effect, but it also has an antagonistic effect on one of the nicotinic, I think only one of the nicotinic acetylcholine receptors, and that is why it can be used for smoking cessation. It is very unlikely to cause sexual dysfunction or weight gain. It is least likely to precipitate mania or rapid cycling. You have to be aware of this. Meth users can snort crushed IR. There's really no reason ever to use the IR, especially not in people who who are past meth abusers. Somebody comes to you with a history of meth addiction, and it says the only medication ever helped me was immediate release bupropion, then you can be sure that he is not going to take it by mouth. Because of the dopaminergic effect, you have to be careful with patient psychosis. Sometimes So this is really not the antidepressant of choice with schizophrenics. It's important to know that it reduces the seizure threshold, especially over doses of 450 milligrams. For that reason, you avoid it in patients where the seizure threshold is already lower. So in anorexia, bulimia, traumatic brain injury, alcoholism, and of course in epileptics. It is also used for many other reasons: smoking cessation, augmentation, lessening sexual side effects, ADD, increasing daytime alertness. It's a very strong 2D6 inhibitor. Again, it is a very strong 2D6 inhibitor, so I just want you to remember that. It's metabolized by one of the rare enzymes, but it's just a curiosity. But it's one of the medications that can very likely cause interference if you add to a regimen and suddenly somebody gets serotonin syndrome, because all of a sudden the serotonin effective medications, the dose is doubled or tripled. So you have to be aware of that. There are some, again, drug company shenanigans with all these brands, but they are all just the same bupropion. Okay, let's go on. Mirtazapine. It's another unique antidepressant. I would say this almost never the first choice, but it's a very versatile medication to be used in different situations. You have to learn how to use it. It has a normal half-life. It is not a reuptake inhibitor. It has these indirect effects that cause serotonin and norepinephrine effects centrally. Do not use together with fluoxamine, because fluoxamine inhibits every single enzyme that mirtazapine is metabolized by. But you can safely use it with other antidepressants. It's one of the strongest histamine blocking. Okay, one of the strongest histamine blocking agents out there. It causes sedation and weight gain. The lowest dose in clinical practice out there, so I mean FDA approved lowest dose is 7.5 milligram. That's the lowest pill that you can order. But some patients use as low as 0.5 milligram that you can get from a compounding pharmacy. And they use it with great efficacy for sleep. St. John's wort, it is here as an antidepressant because it is an antidepressant. It is used in Europe. They took some of the agents out of it and made it into prescription medications. In the US, it is not. It is usually used in these dosages. You have to divide it because of the short half-lives. It is a serotonin, norepinephrine, dopamine reuptake inhibitor, and also GABA and glutamate reuptake inhibitor. It's an MAO inhibitor. It also has other serotonin effects, adrenergic effect, anti-inflammatory effects, and many, many more. And that's called the entourage effect. So the overall effect of the medication is the total effect of the overall effect of this product is the combined effect of everything that's in it, including things that we don't even know what they are. And it's called the entourage effect. Studies show that it's equal efficacy to antidepressants in general. Because of the MAO effect, you have to be careful. It can cause serotonin syndrome if co-administered with serotonergic medications. So if you want to switch to it, you have to look at them as if they were an MAOI. Okay, so that's a quiz, and then after that, let's take a short break.
15 minutes.
Okay, not so short, 15 minutes, says Dr. Myers. Which were your first choice in an antidepressant naive patient? Okay, this is not the same quiz.
It's the same answers. No, it's not at all.
It's not the same quiz.
Doctor, is the slides that I'm having earlier, has it been changed since I have received it? Is it the slide, is it not the number 6?
No, just end the poll. Just end the poll.
Okay.
Okay, all right, then forget about it. So just do it on the chat. Yeah, okay. Obviously, everybody gets it. So let's take a break and reconvene in 15 minutes, which would be 10, what is it? 43.
Just 10:45.
10:45. Continuing, just quickly about the side effect issue, how to manage side effects. In general, there are side effects that are easy to, there's non-specific side effects and specific side effects. Anything that requires a specialist, you will not treat. Anything that does not require a specialist or just requires over-the-counter medication, you treat. In general, again, there are psychiatrists that are more comfortable, there are psychiatrists less comfortable with giving non-psychiatric medication, where there's no really hard set rules of which side effects you should be treating yourself and which side effects you should not be treating. Again, with the exception that anything requires a specialist, you will not touch because you won't know what to do, whether you're a physician or a psychologist. A psychiatrist or a psychologist, anything that you don't know how to do, you will not do.
Blood pressure. Specific blood pressure. Question that he had.
Okay. I'm sorry about this. Yes, there's a Zoom group chat. I type in, I don't know who it goes to. The problem is that, I missed an important question because, there's no, sound or something that alerts me that there's a post, somebody posted a question. So I apologize if I don't respond, but it's just simply, I have to push it to the side of the screen so it doesn't cover my slides. And I just don't always see what people tell me. So maybe Dr. Myers can remind us. Okay. So tricyclics, they come in two major forms, the tertiary amine and the secondary amine. Tertiary amine, that is nitrogen with two carbon atoms, three carbon atoms connected to that. And the secondary, when one of them was lopped off, and that happens during metabolism and makes a tertiary amine, a secondary amine, and they are usually also active. In general, they have typical half-lives. They have many, many useful uses besides depression. And actually, I think nowadays they are mostly used for other than depression. And you're going to be using them very infrequently in your practice. They can be SNRIs and SSRIs, and I'll talk a little bit more about that in detail. They are also antagonizing acetylcholine receptor, histaminic alpha and 1 alpha 2. The most strongly antihistaminic are amitriptyline and doxepin, and there are some names here. They are just for information, but you will never see them in clinical practice. I've never seen them in my life used by anyone. The most serotonergic is clomipramine, which is used for OCD. It's approved for OCD, but it can be used for depression if you want. The least sedating is the cipramine. It's also the least anticholinergic. And during metabolism, the tertiary amines are converted into secondary amines, and that's how you get from imipramine, you get the cypramine, amitriptyline turns into nortriptyline, and clomipramine turns to desmethylclomipramine. These are all individually approved medication. Desmethylclomipramine is not approved as separate medication. They all share side effects, again, depending on, so there's like a range, some of them less, some of them more. Constipation, dry mouth, urinary retention, blurred vision are the ones that are usually the most subjectively annoying. Orthostatic hypotension, again, is in the elderly, mostly sedation, weight gain. Cardiac side effects is certainly overdose that Dr. Myers is going to talk about more in detail. And toxicity, which again is going to be discussed in more detail in the side effects lecture. But again, these are medications with significant side effects, and that's one of the reasons why they are not used so much, even though they are actually very effective for depression. Again, because these are not medication that you're going to be using a lot, I think it's just generally it's good to know when to use them, when not to use them. They are generally not the first choice in any clinical situation, any psychiatric clinical situation. And you should avoid them in patients with these cardiac problems, glaucoma, urinary retention, eating disorders because of the weight gain, the elderly, and high acute suicide risk because they are deadly in overdose. But consider them using as a second line, third line drug in treatment-resistant depression or as secondary medication for insomnia. Very quickly, and I'm sorry I'm going to fly through this, but again, these are most like check a textbook. Consider this a textbook, all the information that is just there to look at if you need to, but it's not something that I really need to read up from the slides. It is mostly used in, so it used to be the antidepressant against which, for instance, Prozac was tested when it came out, and many other antidepressants, but it's really not used anymore. It is used a lot, actually, in child psychiatry or in pediatrics for enuresis, and used for pain, and it's metabolized to the cypramine. The cypramine is mostly a norepinephrine effect. There is no other clinically relevant effect. It's also used for ADD. It has the fewest side effects. And if you want to use a TCA for treatment-resistant depression, that should be the one. Amitriptyline, very, very high side effect burden on this medication. Very sedating, but it's used in low dose for pain, migraines, insomnia, and even itching. It is actually part of one of the most effective medications for itching. Surprised. It is converted into nortriptyline, which is a very balanced serotonin norepinephrine medication. It is less cardiotoxic, and again, you will encounter it mostly as a medication prescribed by others for pain. And again, like I said about the duloxetine, remember that just because the patient says, I'm not taking an antidepressant, the patient may in fact be taking an antidepressant, particularly if they have a pain, any kind of pain condition. That's one of the reasons why it's so important to take a good medical history, because then you say, well, this patient has migraine, so maybe taking nortriptyline. And you're not just going to prescribe a high dose SSRI for a patient like that. And again, it's the trick of naming, just to go back a few more presentations before. So the neurologist is not going to say, oh, I'm going to give you an antidepressant for migraine. I'm going to say, I'll give you something for migraine. And the patient's not going to know that it's taking antidepressant, and it's not going to report to you that I'm taking antidepressant. So you have to make sure that you know that I just lost everything. Okay, sorry, came back. Clomipramine, very quickly, it's usually is approved for OCD. It has a highest risk of serotonin syndrome. You're going to use it very, very rarely, almost never. I hope this arrives quiz. I apologize for the quiz before. I actually changed the questions and I gave the right questions to Aiden, so it was not his fault, it was mine. So the next quiz, tricyclics, which is true. They are safe in overdose. They can be used to treat enuresis. They are less effective than SSRIs. They are the medication of choice in the elderly, and they typically cause diarrhea as side effects. Which one is true? We should have a little music. Okay, so I see that some are responding on the chat. So I would say that with that we have a pretty good response rate. So yes, the okay, so the correct answer is, of course, B. They can be used to treat enuresis. They are definitely not safe in overdose. They are at least as effective, or perhaps even more effective than SSRIs in depression. In fact, as I said, they are the ones that SSRIs used to be measured against. They typically cause the opposite of diarrhea as side effects. And so, Abdallah, let me answer to you. Let me answer that question. Not all used for enuresis, but was that the question? The question was not that all tricyclic antidepressants that can be used to treat enuresis. It just said that tricyclic antidepressants as a group or any member of that group can be used to treat enuresis. So yes, tricyclics antidepressants can be used because imipramine, it is a tricyclics and it is used. Okay, let's fly on. MAOIs, again, these are medications that probably not going to be using, but it's important to know about them. I mean, no, I'm saying not going to be using, but these are medications that psychiatrists use very infrequently, probably not as frequently, more infrequently than it's clinically justified. They're not as scary as they seem to be. I just had a patient, actually I have now one patient on MAOI, but it was her initiative, so I put her on it and it's working very nicely. But these are medications with, it's a lot of trouble to prescribe them and monitor them, so people try not to, usually not going to do them, even though these are very effective medications. The MAO enzyme comes into forms, MAOA, MAOB, and these are the different kind of substrates that they have. So they some metabolize only one, some metabolize only the other, some metabolize both. The inhibitors of MAO enzyme are not inhibitors of the reuptake transporter. So remember that. So these are not reuptake inhibitors, but they still increase the availability of the neurotransmitters in the synapse. They come in two forms. They come in forms that bind covalently to the enzyme. It means that they never dissociate, and so the brain has to generate new enzymes to have MAO available. And the regular form, that the other kind of, like any other kind of medication that only temporarily attaches itself to the receptor and then deattaches itself. In the US, the only form available is the permanent inhibitors. They are effective in the treatment of anxieties, especially depression with anxiety is, if you want to say something that's specific about them, it really treats it very well. It used to be the recommended treatment in atypical depression. But again, SSRIs have supplanted pretty much everything else. Bulimia, PTSD, even borderline, and bipolar depression. There are some dangerous interactions, serotonin syndrome, hypertensive crisis, and mania. Any kind of serotonergic medication, whether it is used for depression or not, and remember this very well, can cause serotonin syndrome. So obviously antidepressants, I'm not going to name them because you know what they are, but what about the others? So LSD, psilocybin, PCP, ecstasy, some medication like tramadol, which is an opiate with serotonergic effect, tapentadol, another opiate with serotonin norepinephrine effect, St. John's wort, 5-HTP, which is a precursor of serotonin, etc. So these agents can all cause serotonin syndrome if they co-administered with the MAOI. The other problem is hypertensive crisis. It occurs if MAO is inhibited and tryptamine is accumulated. Tryptamine is an amine, a monoamine actually, which is actually not a neurotransmitter, but it is a precursor of actually, I'm not even sure what it is, but it is something has to do with, so it comes with fermented foods. Tryptophan is turned into tryptamine. Okay, I'm sorry, this is just. And tryptamine is metabolized by MAO. Certain foods are high in tryptamine, and if you take an MAOI and you eat a food that's high in tryptamine, then you get an extremely high blood pressure at 240, 260 per 120, 140, and these are deadly high blood pressure readings that can cause bleeding in the brain. So these occur in aged or fermented food. So that's another reason why people are just shying away from that, and it can cause mania with co-administered with 5-HTP. So not just serotonin syndrome, but also mania. This is MAO diet. If you give MAO to the patient, then you give something like that. It's available on the internet, so you can download multiple forms.
It's posted as well.
And it's posted as well.
On Moodle.
On Moodle. Nifedipine is an antihypertensive medication, so some psychiatrists prescribe like 5 pills for patients to keep at home, and in case they have a hypertensive crisis, they bite into the nifedipine, which is a tablet. There's a capsule that looks like fish oil, so it's a soft capsule with an oily thing in it. You bite in the tip of it and you squirt it on your tongue, and it gets absorbed very quickly, and it can eliminate the high blood pressure, and then you go to the emergency room. This is the MAOI that was used most frequently. It's a non-selective irreversible MAOI. Has an amphetamine-like releasing effect, norepinephrine dopaminergic releasing effect. Hepatotoxic. Any serotonergic agent, monoaminergic agent, has to be completely washed out before you give an MAOI. Minimum of 5 half-lives. So, for instance, if somebody was on Zoloft, which is a half-life of, let's say, 24 hours, the patient has to wait 5 days after the last dose of Zoloft before they can start taking phenelzine. One of the problems with phenelzine that it is a medication, or MAOIs in general, it's a medication that you would use on somebody who failed antidepressants. But you can't cross-taper to phenelzine, so you have to wash them off. So imagine that taking a patient off antidepressants completely and waiting 5 days for a patient who is already treatment-resistant and very depressed, and then start an MAOI. So it is so difficult to actually start an MAOI in a clinical situation that's one of the other reasons why it's not used very frequently. I had many patients who said it would be so nice to be able to put you in an MAOI, but I can't just take you off a medication and wait 5 days. You're already very depressed. So unfortunately that limits its usability. I just mentioned it very quickly. Selegidine is any other MAOI. It's available as a patch. It is almost impossible to get approved for any insurance company. But if you want an MAOI that is a medication that you can give to patients who have difficulty swallowing something, or the chronic diarrhea, and this is a good medication to try. You should know about it, but you will have very few opportunities to use it. A quiz. Patient who is taking phenelzine is noted to be restless, confused, diaphoretic with muscles twitching. He just started taking something natural for sleep, bought at a local health food store. Or the following, which is the most likely cause? Okay, so I'm going to just go ahead because I don't want to waste more time. The L-methylfolate is, so let's go to the questions. So the best answer is tryptophan. It is directly going to cause serotonin syndrome. If you think about methylfolate maybe causing serotonin syndrome, actually it's not a bad thinking because it might increase serotonin availability in the brain. If you think about thyroid supplement, thyroid directly, I mean, thyroid hormone itself is not, but thyroid can increase the serotonin levels in the brain. So yes, theoretically it can also cause serotonin syndrome, but clearly the one that most definitely is going to cause serotonin syndrome is tryptophan. Would be directly responsible for serotonin syndrome. So, you know, D and E are not bad thinking. If there was a thinking behind it, E would be the correct answer. But D and E are also not incorrect, I would say. Vitamin D and fish oil, nobody chose it. And there was a good reason for that because they cannot cause serotonin syndrome. Let's go to other things here. Ketamine has, I'm going to talk about ketamine more. We're going to talk ketamine more at the PTSD because simply there is less time here and more time there. But something, a few things here that I want to mention. It is an NMDA receptor antagonist. It has weak opioid effect, and there was some noise that maybe that's the reason why it's an antidepressant, but it is not. And it has many, many other receptor effects which are clinically questionably significant. You remember that slide with the depression, the antidepressants, the monoaminergic antidepressants, that it takes 2-3 weeks to get to the point where ketamine enters this chain, and that's what increases BDNF and mTOR signaling and leads to the increased number and function of synapses. And it reverses the synaptic deficits in these neurons caused by stress or depression. Has an immediate effect. It has IV, IM, and subcutaneous routes that are the best. Bioavailability, IM is by definition 100. IV, is by definition 100% bioavailable. IM subcutaneous about 93, 95% bioavailable. The intranasal route that has been approved has a much lower. It's about 50%. It's abuse potential, and but it is. I think it's unlikely that people who get ketamine for depression are going to be later ketamine abusers, because the dose that you use in ketamine in treatment of depression is much, much lower than anesthesia, and that's also much lower than what's used in by abusers. Huge amount of ketamine. This is the way Spravato looks like. It's a little spritzer device that you put in your nose and you spritz into it. Ketamine itself is a racemic mixture of S and R ketamine. S-ketamine is more effective on the NMDA receptor, but R ketamine is also effective, and but also has different effect, and is also less psychotomimetic. So there are studies also to make R ketamine into a different medication. It is not something that patients can take home. It is something that you order through a specialized pharmacy and gets delivered to your office. It has to be administered by somebody to the patient, because the patient, especially if it's multiple doses, becomes too trippy to administer the medication for himself. And frankly, I don't know if you have to be a psychiatrist to be able to administer it. I guess if you can prescribe, then you can prescribe esketamine as well. This is just, I have no idea. It's a Schedule 3 medication, so it's like a benzo in that sense. So it's not a very highly controlled substance. Brexanolone is a completely new slide. Zulresso injection. It is the medication approved for the treatment of postpartum depression. It is a synthetically produced complex of allopregnanolone, which is a natural hormone, and the vehicle molecule, which allows it to enter the CNS. And it's a PAM, a positive allosteric modulator on the GABA receptor. And it has all this kind of interesting effects. As I showed in the previous slides, it reduced the level of allopregnanolone is the result of postpartum depression, but is also seen in general in other depressive states, even in anxiety, and even in Alzheimer's disease. Is administered inpatient as a continuous 60-hour infusion. Okay, now again I can't see my. There are other agents in pipeline, again, just for information. The rapastanol is an AMPA receptor antagonist, works pretty much at the same level as ketamine. It has failed a few trials, but I hope it's going to come out. There's another medication, which is the combination of buprenorphine and samidorphan. Buprenorphine is an opiate. Mu receptor agonist and a kappa receptor antagonist. Kappa receptor antagonism is antidepressant. Right now, we don't have any pure kappa receptor antagonists, so samidorphan is a mu receptor blocker. So if you combine a mu receptor blocker with buprenorphine, that you get a pure kappa receptor antagonist. This is supposed to be an antidepressant. FDA refused last year against medication is tried for treatment-resistant depression as an add-on, which is the reason why I think it failed. It probably would not have failed if they tried it as an antidepressant on its own. I hope it's going to be available. It's going to be a very interesting medication. And here is Botox. I promised that I'm going to talk about Botox, so here it is. It is not approved yet, but it will be, so it's coming. Studies show that inhibiting SAD expressions can reduce the experience of sadness. There are some Cook treatments that I read about that people are supposed to look in front of a mirror, depressed, and try smiling and look at themselves. But it turns out it's maybe not as Cook as it sounds. So studies actually show that if you can paralyze the muscles that convey the look of depression, then somehow it has an antidepressant effect. Now, believe me or not, but it seems to be true. So that's what you do with Botox. You give these, and I have participated in one of this kind of a trial things. They gave me this little trial thing, so I was able to inject it into a mannequin kind of thing. So you give 5 injections into these muscles on the forehead, right above the eyes and the nose. And it gives, it creates a paralysis last for about 5 to 6 weeks. And it creates an antidepressant effect. And there were randomized controlled trials, HAM-D scores, CGI scores, etc., were significantly lower. And these can be the possible mechanisms of action. Inhibition of the proprioceptive feedback, which I mentioned, but interestingly enough, maybe the reduction of social mirroring of sadness. So people don't look as sad, so people don't reflect the sadness back to them. That's another possibility. And probably the scariest thing that I can imagine, there's a retrograde transport of the toxin back into the CNS, which has been shown to be the case. And maybe that's the antidepressant effect. So who knows? This is just really strange, but apparently scientifically sound treatment of depression coming to your neighborhood clinic. Let's talk about the augmenting agents. These are medications that you add to antidepressants. There's dopaminergics, the actual mood stabilizers, and miscellaneous medications. One of the most useful one is aripiprazole, otherwise called Abilify. It has a long half-life. In low dose, it is used for schizophrenia between 15 and 30 milligrams, and bipolar for depression, use it under that dose, usually between, I would say that 10 milligram, 7.5 milligram is the typical dose. It has a long half-life. It has some serotonin receptor effect. It has very significant side effects, especially weight gain, especially akathisia, which you have to warn patients about it. And of course, you have all the usual side effects of an antipsychotic medication. So be careful, but it's a very useful medication. I would say that this should be your first augmenting choice in melancholic and anxious depression. Sometimes it works miracles. In fact, just an aside, even in panic disorder, I have seen anxious aripiprazole being useful. There's brexpiprazole, which is a new form of Rexulti, and I do not see any particular reason why you use it. It came out just miraculously at the exact moment when aripiprazole went off market, went off patent. So it is clearly one of those things that drug companies do to continue their profitability. Quetiapine or Seroquel, it is not FDA approved for augmentation of depression. Aripiprazole is, but it is widely used. Again, use it in low dosages. High 300 milligrams is really the very upper limit for depression. Usually use it lower, 25 to 100. This is a short half-life, which is useful if you use it for sleep. Again, it has all kinds of serotonin effect. It's alpha-1 antagonist, so we have to be careful. It's orthostatic, especially in the elderly. Side effects, especially sedation, weight gain, diabetes. Yes, it can cause diabetes, so you have to be careful. You consider it as a first choice in depression with anxiety, insomnia, or anorexia. Rosidone, otherwise called as Latuda, is a medication that one of the main advantages is that is metabolically much less stressful for the body. It is approved for bipolar depression only, but it's sometimes used for unipolar depression. It has a serotonin effect. The limiting use, side effect limiting use will be akathisia and dyskinesia. So you see that the metabolic side effects are taken out. There is some weight gain, but not typical. If you want to give a second generation antipsychotic to somebody who's pregnant, then this should be the medication of choice. It is category B. And it's very important, does not cause QTC prolongation. But it's also very important to remember that it's a medication affected highly by eating. It has to be taken within half hour after at least a minimum 350 kilocalorie meal. If you take an empty stomach, you get about 50% absorption of compared to one that you take it on a full stomach. So if you take, if you prescribe this medication, you have to tell patients this you have to tell them when you prescribe it, and every time you see them, tell them, because they're going to forget and start taking it differently. Lithium, it's a medication that can be used to augment the effect of antidepressants. Usually, the dosages are lower than in depression. In bipolar. It has a pretty typical half-life, 1 day. It has many side effects. It's all dose dependent. Almost everybody gets some mild tremor, but again, in these dosages are probably not that likely. Increased thirst is typical. Diarrhea, ataxia, which is difficulty walking, confusion. These are signs of toxic lithium levels. There are some interactions with many medications, including over-the-counter painkillers, like the ibuprofen type medications that can increase the blood level. And it has specific anti-suicidal effects. So if you have a patient who is suicidal, it is a good idea just to start them on 300 milligrams of lithium just in case. Cytomel, it is a synthetic form of triiodothyronine, thyroid hormone. It is a medication that, even though it's not a psychiatric medication per se, you can prescribe it because it is prescribed for a psychiatric purpose. Which reminds me, that's just a little bit. So when do you prescribe medications to treat side effects? So you would prescribe medications that you're comfortable prescribing, just as you can prescribe non-psychiatric medications for the treatment of psychiatric conditions. And I am the kind of guy who is more comfortable. I prescribe some non-psychiatric medications for my patients to treat, let's say, nausea. Some others would just send the patients to the primary care physician. But again, this is a medication that you should feel comfortable prescribing because you're prescribing it for a psychiatric condition and not in a dose that would prescribe for someone with a thyroid condition. So you don't use more than 25 micrograms. Okay, so it increases the basal metabolic rate, increases the sensitivity to catecholamines, and it increases serotonin synthesis. So again, you can imagine if you take it with MAOI, it may cause serotonin syndrome theoretically. You probably have to overdose someone with T3 to cause serotonin syndrome. Some other agents, somatogene is not approved for the treatment for augmenting unipolar depression, so I'm not going to talk about it too much, but sometimes it is used. If you do use it, remember the risk of rash. Olanzapine, it is recommended. In fact, it is FDA approved with a combination of fluoxetine for treatment-resistant depression, but I highly suggest to avoid using it because there's a really high risk of severe metabolic side effects. You're probably like with my eating disorder clients, it can be motivating for people in recovery. Yeah. So that's when you have to select patients drugs according to patient characteristics. Try monoamine modulators. This image here is really not to memorize, but to understand what's going on. So
they had a whole class on this.
What?
They had a class on this in nutrition.
Oh, they have it. Okay, so there are two agents in this class, the L-methylfolate and the SAMe, or simply SAM, and they normalize neurotransmitter production by inserting themselves into these cycles if the cycles are not functioning correctly. And they alone, they may work in mild depression, otherwise you can use them as augmenters. Is L-methylfolate. It has a prescription form, which is called medical food, whatever it means. This is the form in which folate crosses the blood-brain barrier. So the theory is that adding L-methylfolate may increase the overall monoamine synthesis. There is something called Enlite or Enbrace. It's a prescription form, and it comes also with unrelated generics as over-the-counter. It's also a medical food, but it, besides the methylfolate, it also contains other activated forms of B2 and other B vitamins. And according to the inventor of this pill, it balances out the different kind of factors that are in this circuitry that I mentioned to you. If you give too much of one, then maybe circuitry gets too unbalanced. So you have to give a little bit of everything in order to be just right, to achieve just the right balance according to the person who invented this particular formulation. So it's available as Enlite and Enbrace. It can be ordered as a prescription. Enlite or Enbrace, one of the two forms, actually they seem to be identical, but with two different names. But it is, if you want, as a medication is preferred in pregnancy, it is something that's going to be easily prescribed to pregnant women because it would be automatically covered by insurance companies. SAMe, it's a methyl donor in the methylation pathway. If you give too much and the patient is folate deficient, then it can increase homocysteine levels. So that's one of the reasons why balanced products are perhaps more useful than single products, and it can provoke mania in susceptible individuals. Again, can be recommended as a single agent. Getting close to the end here, 5-HTP. It is sometimes taken for the sleep medication. This is the chemical that's in between serotonin and tryptophan, and the 5-HTP with the use of aromatic amino acid decarboxylase is transformed into 5-HT, which is serotonin. Again, if you give too much, it can deplete other monoamines in that circuitry, so you have to be careful with this medication. They try to study it for depression. So far has been no positive placebo-controlled double-blind studies. In low dose, some people get benefit for sleep. With high dose, it's probably best to avoid. Omega-3 fatty acids. There are some published studies, placebo-controlled studies. They all showed effect. They increase serotonin dopamine transmission. And actually, just in general, it's good for your body. It increases cardiovascular health. So it is good to take just for that purpose, but it is a good augmenter and associated agent in a treatment of depression. Again, preferable in pregnancy. And just for the sake of completeness, these are the instrumental treatments for depression. ECT is still the most effective form of treatment. It's about 80–90% effective. No other treatment, not even ketamine, gets close to it. It works very quickly. You get about 12 courses. There is inpatient and outpatient form. You use it when there is a need for rapid antidepressant response. So there is acute suicidal depression, psychotic depression, very, very deep anhedonia in the melancholic depression, refusal to eat kind of depression, catatonia. These are when you use electroconvulsive treatment. Requires general anesthesia, but the risks are very low. There is post-ictal, meaning that post-treatment confusion, and amnesia, which it's like basically you're getting a concussion to the brain, so there is amnesia, which clears up. There's some patients who complain about long-term memory deficits. It's considered controversial, but if somebody has it, then I don't know where's the controversy. And it's a little controversial, cardiovascular stressors. So people in bad cardiovascular conditions, so let's say just after a heart attack, you should avoid getting ECT. Otherwise, there is very minimal risk. For instance, you can use it in pregnancy. Other methods, just for the sake of completion, there's repetitive transcranial magnetic stimulation. It is FDA approved for treatment of MDD where one class of antidepressant has failed, but it's not any more effective than the medications. It's very time-consuming, 20–25 minute sessions, 5 days a week for 6 weeks. Very expensive treatment, requires complicated machinery. Some people get benefit from it, but I have seen many patients fail it. And the rest is really, really, really like Haley, what is it called? Hail Mary treatments in really, really very, very treatment-resistant depression that very few people get, and it is done in a very few specialized treatment centers in the US. You just need to know about the fact that they exist. You can stimulate the vagus nerve with a little electrode attached to it, or you can stimulate the part of the brain in the brain stem. And actually, it's approved for Parkinson's disease and essential tremor, but sometimes they use it for depression. And there are some over-the-counter, well, basically not over-the-counter, but some devices that you can get yourself on Amazon and can try to stimulate your own brain through your forehead, and it may have antidepressant effect. Not FDA approved for anything. Bright light therapy, on the other hand, this is a very effective treatment for seasonal affective disorder. These are relatively cheap lamps that you can buy between $50 to $200, come in various shapes and forms. And the fact that it's effective is shown by the fact that it has side effects. Any treatment that's effective also has side effects. It can cause eye irritation, which is obvious because it works through the eyes, but it can cause restlessness, headaches, but it can also precipitate a hypomanic or manic episode in people who are susceptible. So use it carefully in people with bipolar because it can make them manic with bright light therapy. Physical exercise is something that has antidepressant effects. It generates endorphins in the brain. There are some studies show that it has some antidepressant effects. And again, it may precipitate hypomania in susceptible individuals. And actually, some people do it for that purpose. I had a few patients who told me that they like to do it because it makes them a little hypomanic. And the final quiz. 30-year-old male with sertraline 200 milligrams a day, 3 months, still depressed, all the following would be acceptable except.
Oh, gosh. I'm not reading.
Okay, so let's look at the answers. So the correct answer is C. You will not add phenols into any psychiatric, any antidepressant regimen augmentation because of the danger of causing serotonin syndrome. So that's the correct answer. Ordering blood tests to check hormone vitamin levels is definitely something that you can do. Psychogenic testing, nobody picked that, which is correct. I'm a little baffled why people think that cross tapering to duloxetine would be not acceptable. After 3 months of treatment on a high dose of an antidepressant, it definitely would be acceptable, especially if you go by the algorithm of in STAR-D studies. Definitely this should be a very appropriate step. And adding Cytomel to the regimen is an accepted form of augmentation. Okay, so rethink your answers, and we are going to have a 5-minute break right now.